Good morning. I am recording this for the NUR163 group. This is in place of your lecture that you are missing because of the Martin Luther King birthday. Thank you so much for paying attention. Now, if there's any questions or concerns, or if you have any issues, let me know. Make sure that you're using the browser to watch this in because it'll be easier. I will have, of course, information in the email that I send this out on since I am recording. Again, our topic for today is going to be wonderful safety. Yes, you've had a little bit of this with NUR 160, but this is going to be focused on the elderly or the older adult. So we'll just head on into this topic and again, see what we can see. So thank you again for joining me. All right. So we have our elderly patients. We're talking 60 years of age, and age is relative. Of course, it depends on the person's physique. Not everybody ages at the same pace or the same point. Sometimes we see people that are in their 40s and 50s that seem to be older than some of our 60 and 70-year-olds. So geriatrics is getting a new look at from many people, and sometimes the definitions may be changing in your future. So we'll see how that works out because some of our folks are living much into their 90s and very active into their 90s and even hundreds. So safety is the freedom from accidental injuries, according to Giddens. This is in chapter 45, page 428, if you're wanting to look at this information and review it for your exams. And it's ensuring patient safety involves setting up some systems and processes that basically catches these falls and injuries and items that we call safety issues before they occur. Intercepting them is our hope. It's heading them off if we possibly can with prevention. And again, Williams chapter 9, pages 174 to 175, take a look at box number 9.2 because this is where this information came from. Is the most common safety problems for older adults, of course, involves choking and falls. So when we're feeding that patient, we need to be watching for choking, aspiration, making sure they're chewing their foods, they're sitting upright, that they are tucking their chin if they need to, making sure the food is the right consistency for them, etc. After choking and falls, the next one is poisonings. Now, poisonings isn't going out here and finding arsenic or strychnine or something of that sort. Poisoning is due to the improper mixing or additions of medications, preparations, over-the-counters, herbs, and that they have a detrimental effect on that person's system. It's could possibly be, eating the wrong mushrooms, eating the wrong items together that can cause poisonings. Burns are another, and then, of course, motor vehicle accidents. The largest number of accidental deaths in the older adult population, of course, again, is falls. And of course, this number is increasing because we're not as active as we once were. We have vehicles that get us around from place to place. People are not as invested in sports, walking, in our particular culture here in the United States. Too much fast food, too little activity, and our folks, as they are aging, are more debilitated. So the largest number of accidental deaths, or at least that has been reported in the past, usually occur into that ninth decade. That would be in the 90s. But again, we're seeing it in younger and younger populations. So Again, this depends on who's taking the statistics. A lot of our statistics comes from insurance and comes from life insurance that keeps track of the data on what kills who and how did they die, what were their age, etc. Falls or motor vehicle accidents sometimes result from altered vision. So as we age, our vision is decreased. Of course, we have cataracts, we have other issues with our eyesight. Our acuity is not as good. Maybe our peripheral vision is not as sharp as it once was. Approximately 1 out of 4 older adults fall each year, although less than half report that fall to their primary investigator. And a fall is a good indicator that that patient or that person may fall again. Um, so, especially in that age 65 and up. More than 95% of our hip fractures are caused by falls, usually falling sideways. Falls are the leading cause of traumatic brain injury. In 2021, 38,742 people over the age of 65 died from a fall. And it was the leading cause of unintentional death. And I would underline that one, leading cause of unintentional death. Cost of injuries each year is about $50 billion. So it's a lot of money involved in that. Common physiological changes that affect safety include decreased mobility, decreased flexibility, decreased muscle strength, slowed reaction time, gait changes, difficulty lifting the feet, raising them up over the threshold of a shower or a bathtub, altered sense of balance. Again, need those grab bars or canes, or they need to be holding on to something if they have balance issues and postural changes. So the number one part of ours is to identify patients that are at risk and hopefully maybe stem it off, encourage upper body strengthening. Again, you guys have heard me say this about 15 times, Tai Chi. Excellent exercise for older folks. They can do it sitting or standing, and it increases their balance and their stamina as well as their strength. So I want you to think about this. I want you you can pause this if you want to and think about these questions. Um, give examples of how nurses ensure a safe environment. Think about the environment that you work in. If you're working in long-term care, then we're all so busy. Some of the best facilities actually realize that um, having a few extra people on board to ensure safety, making sure that there's a safe environment, is actually less costly. Some facilities haven't learned that lesson. It's a lesson that if you get in charge, if you become a don, or if you become a manager, talk about that. One added person added to the staff. Um, Spending $50,000 may save them from thousands, hundreds of thousands of dollars in loss, um, negligence or malpractice or suits or of being sued. So it would be very interesting to see what those numbers result out to. Safe environment, that implies that we're going to try to prevent injury. We're going to try to prevent electrical injuries, fires, burns, and poisonings. Our nursing staff must be aware of potential safety problems and then also to report those and to make sure that equipment and unsafe um, areas are taken care of. There is strict building code measures like wider halls, larger doorways, no thresholds in showers that we've included in a lot of the newer facilities. If you're in an older building, there's a lot of problems because those older buildings, they may be grandfathered in, but they have smaller halls, smaller doorways, they may not even have a shower. They have a communal shower or a shower area, which kind of decreases their privacy, but it does sometimes increase safety. We have the responsibility for monitoring those areas, making sure that patients, visitors, and members of the healthcare team are involved in looking for anything that might be of concern. And then, of course, having a mechanism where we can report those. both protection and education are, of course, primary nursing's responsibility. So think about your workplace. What are things that are concerning to you? Have you spoken up? What does the nurse what the nurse does individually, what the healthcare system does? We're going to talk about what their roles are. Our nurse, if you work again in long-term care, in hospitals, whatever setting, we need to make certain that we have effective communication skills. We try to identify and prevent hazards in a room. If you work in a psychiatric area where you have suicidal patients or you have depressed patients, you have to be very vigilant and be aware of how easily even simple things like a pair of scissors left out or a ruler or a pen or a sharp object can be used and can actually lead to someone's injury. We need to foresee harmful situations and be aware of those national patient safety goals. They have changed. In 2004, we used to have a long list of safety goals. They've been pared down to the basics of identify the patient using two patient identifiers, prevent infections. Again, part of our job is to prevent infections, make sure that we have clean environments and that our patient is being taken care of. The nurse's role in safety in the healthcare system is for, of course, quality assurance. We follow the fall risk protocols, nursing in services and training sessions, making sure that we are up to date on how to use the Hoyer systems and the lift systems and the stand systems, making certain that we use them appropriately. We've had the discussions in classroom that sometimes in our facilities we're supposed to have two people using those mechanisms, and sometimes we don't. We use it on our own. Well, you're taking, if that's not your, let me warn you with this. If your policy or protocol in your facility says that two people must be there in order to use the Hoyer lift or any other lifting system, and you go ahead and you lift that patient by yourself, you just violated that. And if that patient falls, who gets in trouble? Not the facility. You do, because you violated their policy. That's not their policy. You say, well, we're too busy. Um, not too busy enough to say, this is your policy. I need someone else to come and help me. Miss Manager, you come along with me. Mr. ED, the executive director, go get them. I need someone here. I can't get anyone else. You come with me. And that will change things pretty quickly, or you may change jobs, one of the two. But they need to be held to their policies and procedures, and don't you violate them. Giddens chapter 45, page 430. Okay, we're talking historically, a culture of blame has been pervasive in our healthcare system. Healthcare teams now investigate what went wrong rather than just blaming the individual clinician who executed the error. But again, because of a litigious society and so many, if they could shift the blame to you, unfortunately, they may do so, especially if you violated policy and procedure. Again, we don't want to blame you. We want to look at the system. A just healthcare system will look at the system and the protocols that are in place. What have we done not to support this person? And again, don't be there saying, well, I dropped Sally onto the floor from the Hoyer lift because I couldn't get anyone to come and help me and I was trying to move her. I went to so and so and so and so and nobody could help. No, you just don't lift Sally. You go get somebody else. And then you say, I'm not wanting to fill out an incident report with Sally on the floor. Sally is not going to fall on my watch. So we want to shift the focus to identifying fault to establishing blame to actually noting where the issues are, reporting errors or near misses to improve the system. Now, would you think if you couldn't get anyone to help you move Sally with a Hoyer lift, is that a near miss issue? I stopped from moving her because I couldn't find anyone to help me. That might be a near miss incident. I think maybe I would almost report that as a near miss just to get attention if necessary. But I'm just saying that. I'm not telling you to go out there and do that. You got to think about that. 7 aspects that define this concept of safe culture in an organization, of course, is the leadership, teamwork, evidence-based group, the communication of that culture within that facility, the learning. Is it a just culture? Is it a patient-centered care uh, culture? Patient safety, of course, is the prevention of healthcare errors and the elimination or mitigation of patient injury caused by healthcare errors per the National Patient Safety Foundation. It is our responsibility not to use unsafe abbreviations to try to sell that, try to stick to the full words. Only use what is acceptable in your policy as far as abbreviations. Doing our right, the medication rights, make sure we get all 3 med checks in, scanning barcodes if that's part of our process, reviewing unknown medications, making checklists to help memory and effective communication, and I would add handoff to that. So, we've got a guy who can't see too well. He's having problems hearing, and those are common aging, changes as we get older. Our vision acuity, too bright of lights. I mean, people don't understand, and we need to be getting the communication out there. You need to blog, you need to add this onto your social media that, you know what, bright lights and the fact that we have an aging population, it's not a safe mixture. People need to be aware that using bright lights all the time, having those high beams on all the time, can blind our older folks when they are driving and cause accidents. I think that person should be held accountable. They should get a ticket for using bright lights when they're not needed. When we have issues with our vision, of course, as we age, it's diminished range of peripheral vision. It's our depth perception that decreases, and that can interfere with our ability to judge distances, to judge, how close is that vehicle, how far is the curb, what is the height of the stairs. So that is what we're worried about. Our night vision diminishes. There is, again, glasses that I would encourage people to use in order to improve their night vision. Falls or motor vehicle accidents often result from altered vision. Changes in visual acuity make it more difficult to read labels or small print, and so they can take the wrong medications or not follow the directions appropriately for that medication. Let me go back here. And of course, decreased auditory acuity can put us at the inability to hear what's going on, to hear warning calls, whistles, alarms, or they may not hear the siren of the police or the fire department in time to get over and be safe. Older adult traumas are predicted to increase by the year 2050. It should be about 40%. Because again, we have an older population. We have many more people reaching that 65 birthday. Trauma is the 5th leading cause of death in older adults. Nearly 1/3 of all trauma deaths are older adults. And of course, then there's abuse. Abuse of the older adults who are demented or dependent are more likely to be victims of abuse and maltreatment. Our external environmental hazards include everything that surround our older adult. Older adults are among the highest risk of groups for injury or death caused by fire. Building codes from institutions require safety doors, fire extinguishers, exit windows, oxygen precautions, and other safety measures. Your facility is supposed to have um, a sign where it shows where the oxygen cutoff is, and only people that have been trained in that cutoff should be using that during a fire. But it also helps lead the fire department to know where those cutoffs are. Each institution must have a fire safety plan designed to reduce the risk of fire a quick notification system to the local fire department, protocols for fire containment, and an evacuation plan. Many of your facilities are developing lanyards with little packets that have information on each patient that is in the facility so that these lanyards can be put on their patients around their neck so that if they have to evacuate them, it'll have their medications, it'll have what their history is, what their name is, what their contact of their family is, and it gives the basic information enough so that we know how to treat and how to keep them safe. Those measures have been made in a common place plan in most of your institutions. Check out your institution where you work. Find out what is their plan for evacuation. Be a part of those team meetings and make sure that you know what the plan is and how to keep your patients safe. Be very aware of oxygen storage, oxygen safety. Make sure that nobody is smoking, there's no open fires, and that we're not storing oxygen cylinders uh, to the capacity greater than the capacity for the area that it's being put in. Again, oxygen canisters have to be stored upright. Most of those fires do stem in the cooking area or the kitchen area. So a lot of times I can remember an incident where my mother-in-law had got up, uh, and at that time she was in her home by herself. She had been very cognizant. She was only in her probably early 70s at that time. But mom got up, and it was always her habit to get up, go into the kitchen, heat her water up, and to make her a cup of instant coffee, um, and to get her um, cereal that she always eat the same cereal, have a little glass of juice, and sit down and read her newspaper or turn on the TV and watch the news. Well, this one day she left a hot pad on the electric stove eye. And of course, it was made of asbestos, so it didn't burn, or some type of flame retardant material, so it didn't burn. All it did was smoke up the place, and of course, it charred. Well, it got smoke into the house, and she had a day person that was coming in that would come and sit with her for a few hours each day. And when her day person got there, they said, "Carol, what are you doing outside on the porch?" She said, "I don't know. There's something wrong in the house." And so the day person opened the door, and of course, it was full of smoke in the house, and she had to open the house. So she went around to the back of the house to open the back door so they would have cross ventilation. But it's very easy for people to become confused. Of course, she had Alzheimer's, and then we knew we needed 24-hour care for her, not just day care, because she wasn't making good judgment. She wasn't choosing good choices. So, I mean, she could have easily set that house on fire. Vehicular accidents, injuries due to motor vehicle accidents are more likely to involve our older patient, our older population. Crossing roads is a significant problem for older pedestrians. And think about that. Why would you think that that is the case? Again, you've got your older person standing on the corner. Maybe they don't understand the walk or don't walk sign. Maybe they're confused. Maybe they're, with so much shoving and pushing and pulling, especially in the busy cities. We don't have that in Indianapolis unless you're downtown. It might be difficult for that person to know when to walk and not to walk. One case study revealed that 36% of independent persons older than 70 years of age, nearly 74% of those, were not able to walk fast enough to cross the street before the traffic signal changes. The National Patient Safety Administration in some areas or some towns have actually lengthened those signs, and they have in some areas have a indicator that can determine if there's somebody still in the walkway and not change the light till that area is cleared. Medical problems are twice as likely to cause driving problems for older people. Um, Diabetics who might be on too much insulin or not taking enough insulin can become dizzy or become impaired if they're on antidepressants, if they're on blood pressure medications, etc. So the side effects that are with our medications can cause that. So think about your meds. Which ones would mix together would cause some more issues? In 2018, there were more than 45 million drivers over the age of 65, and 20% of those drivers in the United States. The fatality rate for drivers over age 85 is the highest for any other age group. Motor vehicle accidents quadruple after the age of 85 and are 15% more likely to die. Now, I'm kind of concerned about those statistics. And of course, here in Indiana, it might be a little different here. I would be very cautious to say that because we also have younger people, higher speeds. They've just recently increased the speed to 65 on 465, and so that means that most of these people are traveling 85 miles per hour. Too high of speeds. I've heard of a 30-year-old who flipped their car last week. So I'm going, why in the world? How does that happen? It was high speed. It was going far too fast, and then they couldn't control the car, hit some ice, and they were over into the ditch. So, really and truly, it's also because we have higher speeds. Younger people think that they can control their vehicles without worrying about the speed they are traveling. It actually only takes a couple of seconds longer if you travel at the corrected speed. Um, there's no need for these people to be driving 85 and 95 miles per hour, especially when we have work areas on our interstates that are only allowing 45 miles per hour. A 45 mile per hour vehicle is almost like standing still when you're driving 85 and 95. A little hard to stop, is what I'm saying. So decreased muscle strength. Remember, we lose our muscle strength, we lose our eyes, we lose everything as we get older. So a lot of cognitive changes with our older adult. Thermoregulation is the ability to maintain body temperature in a safe range. Normally, our temperature should be somewhere between 97 and 99%, or 99 degrees, excuse me, 97 degrees to 99 degrees. But as we age, we have less muscle mass, we have less fat. So muscle makes our heat, makes our energy. Fat protects us, it's an insulator. But as we age, we lose muscle mass and our fat. Heat is lost through vasodilation, perspiration, and of course, our internal factors include the muscle activity, peripheral circulation, etc., and our metabolic rate. So, at the type of foods we are eating, whether or not we're staying well hydrated, we're drinking our fluids, taking our medications, and the disease processes. So, a lot of things lend to that. And of course, our hypothalamus controls our temperature. If our hypothalamus is not working as well as it once did, then our temperature regulation may be impaired. Hypothermia is defined as a core body temperature of 95 degrees or lower. Changes in the skin reduce an older adult's ability to perceive hot or cold environments. And of course, again, decreased muscle tissue, decreased muscle activity, diminished peripheral circulation, and reduced subcutaneous fat and decreased metabolic rate affect the amount of heat produced and retained by the body. Remember that the metabolism slows, shivering diminishes, and the highest rate of death of hypothermia usually occurs in patients over 85. Our disease processes such as hypothyroidism, hypoglycemia, and malnutrition also decrease heat production. Medications that decrease environmental awareness, such as barbiturates, tranquilizers, and antidepressants, also increase the risk for hypothermia. And of course, alcohol ingestion is highly dangerous because it decreases environmental awareness as well. Our signs and symptoms of some hypothermia with our patients is a growing mental confusion. Their pulse and respiration rate will slow. skin is too cool or cold to touch with pallor or cyanosis. Their face may be swollen or puffy. Muscles stiff and fine tremors may occur. Changes in coordination, including their ability to walk or balance. Lethargic, apathy, irritability, hostility, and aggression. They may have shivering or may not be able to even shiver, as some patients will lose that ability to shiver because of their aging processes. So, again, continue to assess these patients, make sure that they're kept warm. It may feel warm enough to you, but sometimes having a sweater or something of that sort or a little blanket across their lap will help them stay nice and warm. In case of hypothermia, look for umbles, UMBLES. Stumbles ataxia. Ataxia is a condition that affects coordination and balance. It occurs when the cerebrum, or the part of the brain responsible for muscle control, is damaged. Mumbles, uh, what they're saying is they have multiple words. I'm not for sure I can even say this. I'm going to put this over so you guys can read this. So sometimes I look at the notes and I'm going, what are they saying? So here it is. So they're asking us to use the word UMBLES and then build on that. You add ST to the front and you get ataxia and difficulty walking. MU, that means they have difficulty speaking. They may not be clear in their speech. They lose their fumbles. They lose their fine motor coordination and CNS. And if they have grumbles, that means they have lethargy and irritability. Sometimes hypothermia, like it says, can mimic stroke symptoms, and also watch for their glucose levels. As the patient's blood sugar drops, they may become cold because their metabolic uh, response is also dropping. Okay, it says have students list some medications, instances that can cause hypothermia, such as long surgeries, sedatives, hypnotics, etc. Think about that again. When we have heart surgery, they intentionally make the person's body temperature go below 95 degrees so that they can slow processes and slow metabolic processes and stop the heart so that they can replace the heart vessels. But we don't want to do that unintentionally with our patients. Warm beverages, I would point that one out too, is warm beverages are great because they're appropriate, but not hot. They may burn themselves with hot beverages. So let's see what we got here. How does hypothermia kill? So apparently we have a video here. Let me get this out of the way. If this doesn't play, I will put it on SurePath so you guys can watch. Well, this is not the one we want, so let's see if we can get the right one. So that was quite interesting. I hope you were able to hear that. I'll check the video, of course, before I send it out. But if not, if this wasn't a good loudness, you can watch it on YouTube. Okay, external factors, continued thermoregulation and hyperthermia. Hyperthermia is higher than normal body temperature and occurs when the body is unable to get rid of excess heat. Hyperthermia is caused by, of course, environmental temperatures that are above the ability for the body to stay at that 98.6 to try to cool it. It's excessive. It can also be worsened with excessive exercise if they have an infection or if they have hyperthyroidism. Your thyroid is too overactive, it causes you to be heat intolerant. When high heat is combined with high humidity, the normal cooling mechanism of the body becomes ineffective. That is not what I wanted yet. Older adults are at higher risk for hyperthermia due to, of course, a number of mechanisms. We've shared some of those in the past. So first of all, this guy looks like he's not well hydrated. Um, they don't have older adults don't have good water volume in their system. So if they don't have good water volume, they're going to be very apt to be heat intolerant. If they begin to sweat, it's usually a long time before we get to the sweating point, so they don't perspire as much. They can develop heat exhaustion early. Cardiovascular problems and heat are deadly combinations. So if they have heart issues or endocrine problems, such as diabetes, psychiatric disorders, also increase the risk of hyperthermia. Diuretics also prevent the body from storing fluids and can diminish superficial vasodilation. Parkinson's disease can interfere with perspiration, as does some other uh, mobility type diseases such as MS, myasthenia gravis, etc. Consumption of alcohol should be avoided because it also decreases awareness and it also contributes to fluid loss. So, what are our signs and symptoms of heat stroke or heat intolerance? The mild early signs of heat stress is just feeling hot, listless, and uncomfortable. And then they may have leg cramps, arm cramps, or abdomen, so muscles start cramping. Elevated body temperatures, serious heat problems may include hot, dry skin, and you won't see them perspire. They'll be very red in the skin, tachycardia, chest pain, breathing problems, throbbing, headache, dizziness, profound weakness, mental or perceptual changes, vomiting, abdominal cramps, nausea, and diarrhea. So they're going to lose even more fluids. If you get a patient that has heat stroke or heat exhaustion, we need to get them cooled down quickly. We need to get fluids into them. We need to get them out of the sun and into a cool environment. Sometimes we've even taken blankets, made them cold with cold water, ice, etc., trying to get their temperature back down. They can get a temperature of 104 degrees higher, the more life-threatening it is. If it gets to 105, 6, 7, 8 with their core body temperature, we're talking brain death. So very important to get them their temperatures down. That's true for any age group, young to old. So let's talk about medications with our older adult. Of course, sharing medications with friends is a common practice, unfortunately, with our older adults. And of course, they're unaware of those dangers. It may be that your medication varies. It may be that your medication is of a different strength, maybe of a different area. So don't share. You don't want to share your medications. It can cause drug interactions. Make sure that you're taking what your doctor prescribes. Over-the-counter medications, they need to understand that certain meds may interfere with one another. The St. John wort may cause their antidepressant to be stronger. It can cause issues. Um, Many don't think that they're over the medications as real. They don't think of them as drugs. They think of, oh, well, they're, I just pay for them. They're out there on the, on the store shelf. These don't cause any problems. And we need to, of course, educate them. We also need to tell them about alcohol and mixing different things. May not, some of your meds do not mix with alcohol, not to take it with certain foods. Make sure that they're following the directions and that they clearly understand when it should be on an empty stomach and when they should have it with food. They may fail to take their medications, and of course, then that causes some issues because of cost. Gosh, the cost of medications, has it ever interfered with your ability to afford that med, to get that taken care of? A lot of times we prescribe a medication because it's the best medication for the patient, but then we find out that the patient can't afford it. So then we're having to rethink our treatment as a nurse practitioner or as a physician. As a LPN or a registered nurse, we need to be asking them, is it because you can't afford this med? How much can you afford with the medication? Because we know some meds are expensive. Things like Eliquis and Rivaroxaban, those medications that are newer on the market are going to cost more. We may have to go to an alternative that is an older med like warfarin, in order to provide the same care. Knowledge, skills, and attitudes. So let's talk about knowledge. Contemporary nurses, we all need to be knowledgeable in examining human factors and other basic safety. We need to feel that we have the right and the ability to choose safe practices, to encourage those, and to speak up or speak out if those practices are not being followed or if they're not being supported by the people that we work for. We need to describe the benefits and limitations of selected safety enhancing technologies such as barcoding, using identifiers, etc., barcoding on medications, making sure it matches what the MAR is showing. We use a lot of alarms and pumps and things like that, but we still, even though the pumps are automatically computing drip rates and things like that, you still need to know if that drip rate is correct. Put the wrong numbers into a calculator, it'll spit out the wrong answer. There's no intelligence in that calculator. Now, we do have AI, and we do have AI within our computer systems these days, and I have a feeling we're going to see more of that. But the thing of it is, you need to be smart. You need to have the ability to know that 21 drops per minute is the correct drops per minute. Just don't depend upon the machine. You must understand the processes used in understanding the cause of error and allocation of responsibility. Skills are your number one tool. It is very important for you to develop skills and to keep up with the safety in skills. If they get a new IV pump at your place of work, you need to attend the in-service on how to use that safely, know how it all works, know all of the intricacies of that pump. Every pump works differently. Every pump has a different yeah, way of working to use it safely. We have the responsibility to report errors. Again, if a machine falls off a table or is knocked over onto the floor, then we need to take that out of service until it can be checked, not just to use it. Oh, well, we'll just go ahead and use it. No, don't use it. Make sure it gets checked out. It's our attitude and our internal. Would you want that piece of equipment, that med, or that nurse to take care of you? Would you want a nurse just like you? If you say, yeah, I'm the best nurse, then you're good to go. If you're doing all you need to do, but I'm going to tell you, you need to look honestly at your practices and at your work ethic, okay? Incidence of falls again, it's the second leading cause. I don't know why they put this here, but we're going to go risk of injury from falls is the highest after age 75. I think this is just a quick review. So there's your review for incidence of falls. Factors that increase the risk of falling again. I don't know why these are here when we talked about falls previously. Again, the increased risk, hemiparesis, if that person has paralysis or sensory impairment, diabetes. So know these increased risks of falling factors. They may appear on a exam. I haven't actually looked at your exam yet because it's not there for us to look at quite yet. Fall prevention is the number one thing that we can do, is prevent environmental issues that may put us at risk, may put the patient at risk for falls. Exactly. That's sometimes why Medicare is now instituting these home visits. They're sending, because the majority of our older patients are not into facilities, they're in their homes. And going into the home and looking at rugs that uh, don't have the little rubber bottom that holds them in place too easily for patients to get on one of those and they slip out from under them. Reducing fall-related injuries again, individuals at risk for falling can be taught to rotate forward or backward to avoid falling sideways. So it's how you fall that sometimes can cause the worst injuries. Again, sideways fall can break that hip a lot easier. And if they have osteoporosis, they're going to have an increased risk for falls as well. When a fall occurs, of course, we're talking about hospitalization, long-term care facilities, transitional care. That fall may result in a lot of pressures and changes within the family dynamics. Um, it can also, of course, cause depression and feeling useless and worthless in our older patient who used to be independent. Now they can't be independent. Um, we need to take steps to remove or correct the cause of those falls, inspect clients for injury, and in the home setting, have a plan of action how to get up and seek help. All of our patients that live at home should have a fire plan. If they have a second story, should have at least thought out how they would get from the second story if there was a fire, etc. Restraints. We don't try to use restraints. In a lot of our facilities, we're restraint free, or we say we're a restraint free facility. Physical restraints is anything that restricts the movement and cannot be released by the patient. It takes a physician's order for those restraint use. It must be specified for duration and circumstances and under which the restraint can be used. Chemical restraints, there are medications that also restrain. Never use psychotropic drugs for the purpose of discipline or conveyance, meaning the Xanax, the alprazolam. Um, Use only when danger of self-injury or injury to others. And then, of course, the administration of psychotropic drug requires a physician's written order that specifies the duration and circumstances under which it will be used. State boards of health are coming into facilities. They're looking at the Xanaxes and alprazolams and the different anti-anxiety medications. They're asking us to use the lowest effective dose and only for short duration of time. So we also have to wean patients off of those and then see if they can, if they actually need them. We need to bring in a psychiatric evaluation in order to determine if it needs to be long-term and have that support from the psychiatric. The facility I used to work at for long-term, um, I could order those medications for short-term, but then we had to bring in the psychiatrist or psychiatric MD to come in and evaluate whether or not that patient needed that for long-term. And it was then that controlled the duration of that medication and weaned it or took it back off the patient. The Food and Drug Administration reports at least 100 restraint-related deaths each year. So do deaths still occur? Yes. Make certain that you realize that our goal is 15 to 30 minutes. We're checking on that patient. If they're under the restraint, we're checking for capillary refill, we're checking pulses. Again, you're in that room every 15 minutes, and then every 15 to 30, you're checking those pulses. So it may be you're putting your eyes on them the first 15 minutes. At 30 minutes after, you're checking for pulses. Next 15, you're putting your eyes on them, and the next at the top of the hour, then you are also checking their pulses once more. And then remember, every 2 hours, you have to take those restraints completely off and do range of motion. So what are some better alternatives to restraints? Think about that. What are distraction? Um, See if they're got to go to the bathroom. See if they need to have pain relief. If they're acting out or if they're getting combative, maybe it's due to pain. Maybe, check to make sure their shoes are not too tight. Make sure they don't have a whole lot of swelling. Make sure they don't need to go poo-poo or they need to go to the bathroom to pee. Get them up, move them around, get their pressure points and stuff. Put on a show that they might enjoy on TV. Give them an activity. Try try all different alternatives. Talk to other nurses. See what has worked. If you can't do that, then again, every 15 to 30 minutes, check that patient frequently. Again, I don't need to repeat this. Alternatives, give them physical therapy. Sit and talk with the patient for short periods, give them tasks. Um, if they need to walk and they want to walk around and stuff, take a walk with them. Who's on break? Uh, get them tired out is basically what you're going to do, is so that they will be able to sleep well. Which of the following is not true about injuries and falls? So the correct answer is C. Is the rationale of older adults because of intrinsic factors or factors related to the functioning of the individual, such as the aging process or physical illness, and intrinsic factors or environmental factors is what they're saying. Again, falls occur in older adults only because of intrinsic factors or factors related to the functioning of the individual. That's not true, because anyone can fall. Even I think I've fallen a number of times when I was in my 20s. Think about the last time you were out and about and you tripped. Yep. Yep, it's working. Yay. Which client is most likely at risk to become a victim of elder abuse? And when you're determining this type of question, you have to think about, okay, which patient is going to put a stress and strain onto the family dynamics? What disease processes can really cause the patient's family to feel like, there's no way that they can take care of this person any longer. Sometimes you get to your wits' end, because you're having to struggle with this patient. So it may not be the 75-year-old who has got moderate hypertension. And it may not be the 68-year-old man with newly diagnosed cataracts, because that can be fixed. What about this? Let's go to number 4. What about the 70-year-old woman with early diagnosis of Lyme disease? Well, again, that's limited. It's not going to be for a long time. Oops, I didn't do it this time. This time the answer is 3. It's the 90-year-old woman with advanced Alzheimer's disease, because um, there is a lot of stuff. You have to be extremely patient to work with patients that have Alzheimer's, because there's so much repetitive. There's so much. They may ask the same questions over and over and over again, and that's, it's just because their brain is stuck on that groove today. So it can be difficult for the family. The nurse is applying wrist restraints prescribed to prevent a client from pulling out a nasogastric tube. How would the nurse determine that the restraints are not too constrictive? Observe the skin in the wrist area for redness. Check the temperature of the skin in the hands. Remove the restraint and exercise the extremity in 2 hours. or place 2 fingers under the restraint to determine snugness. Remember, when we place that restraint, we're going to actually test for snugness, and I don't know why they didn't have these. Okay, they're not going to give us a nice little underline here. In that instance, I'm going to pull over the big slide here for you to see. As you can see, here's the information that they gave for that and the answer. So we do want to place 2 fingers to make sure it's not too snug, so that we make sure that the circulation is good. And that's again on Saunders. If Saunders is awfully good for the the down and dirty. Here's the last question. I'm going to just leave this over here so you can see it. A client arrives to the emergency department and has experienced frostbite to the right hand. What would you expect to see when you were assessing that hand? White color of the skin, which is insensitive to touch, okay? So the findings are going to be white to blue skin color for frostbite. When we first have, again, cold exposure, our skin starts getting kind of pinkish to fiery red, and then they may be swelling and stuff in the area, but as the frostbite becomes worse and worse, then the skin loses its color and it becomes more numb. Okay, this is everything I have for you today. There looks like this is the last slide, and it is. And this is where they're going to end it. Looks like I'm going to be giving some time back to you. Again, review for quiz number 1. Make sure that you go to through your lab. Look at your lab manual for both weeks 1, 2, and 3. So this first quiz is over all 3 weeks. Even though you will not have your lab till after the class, make sure you know about your different colors of exudate, that you know the national safety goals, that you know the things that we covered when you were in lab last week, and that you're ready for those 20 questions. We will take the time for you guys to go ahead and start on week lab 3 reading and working on that, so that I can grade your quizzes, and I'll try to give you your results as quickly as I can. Thank you again for participating. I greatly appreciate your time, and you have a great day. Whatever day it is that you're reviewing this, I'll get this out to you as quickly as I can.